Good afternoon and welcome from Toronto, Canada. My name is Anna Sangster from the International Federation on Aging, and it is my pleasure to be with you here today to bring you the latest webinar in the WHO IFA Age-Friendly series entitled Age-Friendly Rural Communities. Are they possible? It is a privilege this afternoon to be joined by Dr. Kathleen Brasher, Principal Strategic Advisor for the Age-Friendly Northeast Victoria Alliance. Kathleen is not only an expert with vast experience working both in partnership with and for government, but she is also a wonderfully thoughtful and reflective professional whose unique perspective and dedication to working at the coalface with older adults has had tremendous influence on age-friendly work around the world. Kathleen has also been kind enough to join us from Australia, where it is still the wee hours of the morning, so we are most grateful that she was able to join us today.
Thank you very much, Anna, and thank you to the WHO and IFA for this opportunity, and welcome from an early morning in Australia. I want to begin by acknowledging that I'm standing on Pangarang country, and I pay my respects to elders past, present and emerging. And that acknowledgement of elders is a practice that we do in Australia, and it reminds me each time I hear it that for our First Nations people, elders are held in respect. I also want to acknowledge and pay my respects to elders from all countries joining us today. I'd also like to acknowledge the support of the Age-Friendly Northeast Victoria Alliance in the work that I'm about to present, and the support from the Department of Health and Human Services, Ovens-Murray Region, and Central Hume and Primary Care Partnerships. Rural communities, the country, the outback, the frontier, the interior, the bush, they're places of inherent paradoxes. They're places that have fewer and poorer services of all sorts, and yet rural older people in particular say that they're much more satisfied with their lives than their urban counterparts. They're places of vast geographical spaces where people are more isolated, and yet people report having a sense of stronger social connections. And they're places of great and intractable inequality and inequity. And still people report that they feel safer and that they feel more cohesive as communities. So these paradoxes we need to hold in our mind as we think about what it means to be age-friendly in rural communities. But I want to start by trying to define what I mean by the word rural. It is a word that doesn't have a worldwide agreed definition, but most academics and most government agencies agree that it comprises two distinct components, that it's a locality that is very distinct on statistical measures, but it also is a social construct. It's how we feel and identify as being part of a rural community. As a statistical measure, there's variation around the world, as you can imagine, about what that means. In the United States, the number of people who reside in a given landmass defined as the frontier are places that have fewer than 6 people per square mile or 2.4 people per square kilometre. So when you overlay that with population, and if you just look at the green components of this slide, that's those who live in non-metropolitan and what are called micro-metropolitan communities. And the darker the colour, the higher the proportion of older people. You can see that that frontier space also matches with increased proportions of older people. In Australia, rurality is defined differently, and it's classified according to an index of accessibility and remoteness that measures distance to service. So you can see in Australia, people that are closest to services live in those major cities around our seaboard. And the further you go into what we would call the outback or the interior or the frontier, have significantly less access to services. Again, if we overlay that with population density, it matches proportionately across that, of course. So the closer services are, more people live in areas where there are services, and significantly fewer people live in areas without those services. In the state of Victoria that I live in, that's on the bottom right-hand side of the map, just above the island of Tasmania, within the next 5 or so years, 21% of our population for the whole state is expected to be over 60. But in the region that I live, which is on the east or the right side of the state of Victoria, for the same time period, 35% of our population will be over the age of 60, and it will be equal in number to the population of Monaco. So in and of itself, the proportions and numbers of older people are significant. It is important to note that the middle bit there looks quite empty, but it's actually populated with small numbers of First Nations people, and those communities are dotted across the continent. And importantly, the more remote you go for those communities, they tend to be younger than non-Indigenous populations because of this significant gap we have in life expectancy of our First Nations people. But that experience of living on land brings me to the second way of understanding rurality, and that's as a social construct. And that the notion of living in a rural community is indissoluble from land and from people. So this importance of how the diversity of the land itself, what it looks like, what it feels like, its soil, its weather, its topography, shape the people themselves. First Nations people are the oldest living continent on Earth, and land is just one part of what they call country. And that's their connection with all living things, their ancestors, their creation story, and their culture. And it's a cultural responsibility for elders to live on country, to maintain that cultural knowledge, and to provide intergenerational caring and learning. For us as newly arrived non-Indigenous people, we're starting to learn from Indigenous language and culture about what it means to have that reciprocal relationship with the land. And so for all older people, the diversity of the land shapes where we live, the seasonal patterns of what we do, and how we live our day-to-day lives. And along with the land shaping us, being in those small communities shape us. So as well as dealing with negative stereotypes of what aging means, we're also faced with negative stereotypes of what it means to be from the bush, and that older people who live in country towns are slower, that they're stuck in their ways. But that social identity of living in the bush is also marked by having quite strong social bonds and reporting much higher levels of self-autonomy and resilience. And it also is linked to poor health and greater health inequalities than those who live in urban areas. So just to give you some of the statistics about that, all these graphs are presented in the same way, with the major cities being at the top of the bar graphs and that darker colour. And then as you become more remote, you go into a lighter colour blue. And so we can see that people who live in rural and remote areas are more likely to have a higher prevalence of all of the known risk factors for poor health outcomes. And correspondingly, they have higher rates of chronic conditions from both mental, physical, and psychological health outcomes. For people over the age of 45 living in non-urban settings, they're less likely to have their medical team consult with each other, or indeed to have medical care nearby. So very few specialists, and in some communities, no GPs either. So no primary care network that is accessible and available to people as they age. And so not unexpectedly, there's a higher proportion of potentially avoidable deaths in rural areas. So given this somewhat complex and paradoxical picture of what it means to grow old in the bush, how do we create age-friendly rural communities? So today I want to share some of what I'm learning in my work and life in regional Victoria and my work across the country. And it's beyond the scope for me to actually give a more nuanced description of what it means to be of colour, to talk about race, religion, class, and they all matter deeply. But I can only touch on those briefly today. And it's also clear that many of the issues that affect us as we age in rural communities are absolutely the same that affect people all around the globe. So what I want to just highlight are those issues that are specific to rural communities. It's really important. Oh, sorry, I'm going forward now. My apologies. It's really important that we acknowledge that rural communities are an important part of our progress towards the Sustainable Development Goals and to achieve prosperity for people and planet. And so this is the highest level of policy that helps guide our work here. And with the launch of the Decade of Healthy Aging on the 1st of October this year, the decade intersects with the Sustainable Development Goals, and it calls on all member states, and rural communities are part of the member states of all of our countries to bring sustained effort to try to address ageism, to create age-friendly communities, to reorientate the health system to be more supportive of older people, and to ensure access to long-term care. But along with the significant need to address population, we have now two generational defining challenges that we must include in our age-friendly work. And the first of those is climate change. Climate change is already having a significant impact on older rural people. Their communities are changing daily. And with increasing and extreme weather events, it increases the vulnerability for older people. This is an image from the extraordinary and catastrophic fires that Australia went through just recently from just near my home. And as an outcome of that work, we've created a resource that will be available to you if you're interested about how to take an age-friendly approach to disaster recovery. And of course, the second major impact is the global pandemic. As of yesterday, Australia had 905 deaths from COVID, and 90% of those deaths were people over the age of 60. Of all of those deaths, 75 of them occurred in the for-profit residential aged care facilities. So, our hearts are with all of those families that are suffering. And along with the morbidity and mortality that's occurred because of COVID, we've also been part of that global community that now seems to have to justify the worth of a long-lived life. So we do need to build back better, as the phrase now seems to be strongly resonating around the world. We've got to maximise the potential of older people and their basic level of health to ensure that they're resilient and adaptable in the face of these events, and to support the economic recovery that the world needs. How we achieve it is through collective action. And one of the really important things is that rural does mean regional, that older people, all of us, have a place we call home for a whole lot of diverse regions, but it very rarely aligns with a municipal government boundary. So we need collective action that brings together the diversity of small rural towns to recognise their difference, to unite around those differences, and to have an approach that doesn't say one size will fit every one of these communities, but that together we can share people and resources, and we can expand service deliveries and undertake those major infrastructure challenges that we need to address. And the way that we've been doing it here is to use the Global Network for Age-Friendly Cities and Communities four-step process that requires that participatory response and is done with, for, and by older people, with all levels of government and all parts of government and civil society. And to give you a brief idea of what that looks like, I just want to use the wheat belt in Western Australia as an example. So they created age-friendly wheat belt. The wheat belt is an area of 154,000 square kilometres. So it's a little bit bigger than England. It has over 200 small towns spread across the wheat belt, and it's divided into 42 different local government areas. So they came together to create an age-friendly region. They all did their own, they used the same resources to assess each of those community towns. And they came up with a shared approach that meant all regional towns would become age-friendly, and they would work to try to achieve that. But they took housing and care support as a crucial plank, as they called it, for their first plan of action, and recognised that not every town would have residential aged care services, and indeed not every town would have home care and support able to reach it. And older people recognised if they were in towns that were too small to support those things, that if they needed them, they would need to move into a neighbouring community. But with those age-friendly communities being developed, it's hoped that people can age in place for longer. So I want to start looking at the work that we're doing here in regional Victoria, and that's mirrored in many regional and rural communities across the world, by talking through those determinants of healthy aging, or the age-friendly domains. They are deeply interconnected. And so it's really important to state that at the outset, that although we talk about them individually, they are so interconnected as life is. And much more is known about these determinants in urban areas. There's an increasing amount of research being done in rural communities, but it still significantly lags behind urban areas. And I also want to, as we go through each of them, talk about how we do build back better coming out of COVID, for those of us that are coming out of our second waves. And I certainly understand that for Europe, that it's probably still too early to start talking about building back, but it's really important that the age-friendly agenda is on that program of work. So the built environment, as I said, is deeply interconnected, that transport, housing, and being able to use those outdoor spaces are interconnected. In small towns, particularly those that are struggling, there's often quite poor infrastructure. This is actually a photo of my local community. We have one shop. We have no footpaths. We have deep gullies when it floods, when we get big rains that we do have. Often in spring, those gullies fill, and it can be quite difficult to access. What we've found is mapping communities to think about access of services for older people is a really useful way, because the infrastructure is not going to be built across the whole of the community. So this is some work that RMIT University, led by Dr. Davin, has been doing, where we've designed a measure of access to services, those services that older people themselves find valuable and important, that they use frequently. So it's not just based around health services. And then we're able to use that indicator and geocoded data to say where are the gaps in small towns, so that we can begin to think about how town planners can work where older people live to develop services, or at least to cluster services together, and then put housing that's accessible and affordable near those services. Similar to urban communities, outdoor spaces and walkability is crucial for physical, mental, cognitive and social benefits as we age. They are highly protective of our health and well-being as we age. So similarly to urban settings, we can measure the amount of public open space that's available, the tree canopy of that open space. But in urban settings, we talk about 400-metre access to public space as important for physical activity and social connection. That doesn't necessarily work in rural communities where access to public open space is about the natural environment in which people live. And when rural people talk about the beauty of the natural environment, their land, older people actually report higher levels of satisfaction with life, higher levels of mental health and well-being, because they're the place that give us meaning. It's why we're here. So the impacts of extreme weather events, and again, this is my community under flood 18 months ago. Those extreme weather events, prolonged droughts, floods lead to more damage to critical infrastructure and poorer physical and mental health outcomes. And it places even fit and well older people can be placed into vulnerable situations. So age-friendly communities, we need to work with our planners, work with all levels of government to increase those accesses to green canopy and to blue spaces in our rural town, as well as providing public buildings for cooling. And for those of us that have severe winters, obviously that's heating as well. And in activities that older people can do, they make a significant difference to adaptation to climate change and to improving the land in which we live. And Landcare in Australia is a not-for-profit organisation that started in rural Victoria and now is across the country, where groups of volunteers come together to improve both public and private land, and a significant proportion of members of Landcare who volunteer their time are older people. And it's been a great way in which older people have taken a leadership role in improving those green spaces. So when we think about what an age-friendly agenda looks like moving into a post-COVID world, it's working with planners, working with private companies to create those walkable and accessible main streets or high streets and to think about what they mean in a COVID normal world, but also the importance of prioritising access to community spaces. And that's particularly important for First Nations people, that there's a safe community space for people to come together. When we think about transport, older people drive, country people drive, and so maintaining the ability to keep up their physical health to be able to drive is really important. Given that dispersed nature of towns and people, the research is absolutely certain that it's transport that's central to health and well-being for older people living in rural communities, that it's central to their participation and to their independence and health. So some of the work we need to be doing in age-friendly work is to ensure that older people have access to programs that maintain their physical, mental and cognitive skills, and that those are made relevant because they want to keep driving. It's a great driver to get people into gyms. Public transport is often sparse, and small towns are often designed around cars and car access. So it's really important, particularly in areas where there's extreme heat, that we work with planners to try to create pedestrian towns rather than car-based towns. So again, it's an opportunity. So this is another example from one of our rural communities, Tolmi, in the Shire of Mansfield. As part of their age-friendly work a few years ago, they created a program called Toast. Tolmi offers a seat to town. It's community-led, community-run, where if someone's going from Tolmi into one of the regional towns, they can offer an older person a lift and though the time when people are going in and out of town can be negotiated. So it's a simple, there's lots of community transport models available, and this is one that's simple and effective. One of the ways of obviously stimulating economic economy in a COVID normal world is to undertake major public transport initiatives. And for our age-friendly work, we'd like to see those public transport initiatives include and examine the needs of people in small towns to have public transport that's not only accessible and affordable, but is flexible and connects towns where older people need to go for services and also for the things that they enjoy doing. Housing is the third of our built infrastructure that is integrally linked to transport, and it's integral to access. You need to be able to get out of somewhere safe and secure to go to somewhere that you want to go. So living in secure, affordable, appropriate housing matters. In the communities that I live in and in many rural communities around the world, older women are more likely to live alone than any other population group. And so the care and maintenance of houses can be an issue for older women. The cost of housing, as some rural towns are favoured by urban people as holiday destinations, which can increase the cost of housing and the availability of housing. And we know that poor housing is linked with early entry into residential aged care, and it's also linked with poor health outcomes. So many rural communities are missing what's called middle housing or right size housing, that people can't leave farms that are sometimes tied up in family trusts or leave buildings that no longer meet their needs because there's no right size housing to move into that has services nearby. So again, we need to consider what those housing models look like. Sustainable housing is also really important, and this is an example of totally renewable Yakandanda, which is a community-based initiative in the small town of Yakandanda that has about 2,000 people, and about a third of those people are already over the age of 65. And TRI was established as a community group drawing on the industry knowledge and academic knowledge of older people in the community with younger people to set the goal of powering the town by 100% renewable energy. And people in the town raise funds and apply for significant grants from government to ensure people who can't afford to put solar cells on their houses are able to do so, and to put solar cells on public buildings. So it takes a whole of community approach, and it uses the volunteering power of older people to generate the energy to get those services set up. And part of, again, the economic stimulus that governments need to be looking at to get age-friendly on their agendas is public housing infrastructure. So housing that absolutely meets the needs of the 5 generations that are alive together at the same time. So our housing needs to be built that has that adaptability, and it needs to be housing that's adapted for climate change, to reduce the costs, and to make housing that actually forms part of the community. Often, particularly residential aged care facilities are built on outskirts of town where land is cheap, and we know that it's much better for everyone if, and older people can actually live in communities much longer, much more efficiently and effectively if they're close to services. The second major group of social determinants of healthy aging is the social environment. And this is one area where rural communities actually do really well. It is our strength. That when it comes to social participation, older people report that they have a higher sense of belonging. They're more likely to participate in all aspects of their community. that being part of a rural community gives them a sense of identity as well as friendships, and that they have this strong connection, not just to the land, but to others. And they move in and out of community organizations and pitch in to support when support's needed. I want to tell you the story of Maggie, who's a friend of mine. She was living in an urban city, and she returned to her rural community after a family tragedy with her two small children. She was finding it incredibly difficult to manage in her urban community, where she said you always felt the need to put on a mask to just show that you were coping. And she described when she went back to her rural town that the community, which were mostly older people and older women, weren't afraid to step into the gap in her life, even when it was uncomfortable. And that need that ability to move in and support even without being asked was ultimately part of her healing. So we know that older people bring moral wisdom and strength into the lives of others, particularly at times of emergency and community. And COVID has obviously dramatically affected ability to participate. But there are ways for those with internet access. We've seen this boom in reading time for grandchildren wherever they are over the world, playing games on computers and things with children and grandchildren and great-great-grandchildren. That true Zoom trivias, family celebrations have all been able to be connected if you have internet access, and people have still been able to keep up that social connection with others. And as with all of us, ageism and elder abuse impact people living in small rural communities as well. And while social participation is part of the superpower of rural communities, it's also their kryptonite. That same social participatory approach, that sense of cohesion, can also in rural communities be hierarchical, it can be gendered, and it can be divided by class and race. So along with the impact of age discrimination, some members of our community have multiple forms of discrimination, and that gives rise to significant levels of isolation and poor health outcomes. And sport is often pointed to in rural communities as the great leveller, of the great place where people can come together. But research has shown that sporting clubs in rural communities are often sharply divided and exclusive. And older people in rural communities can be divided on the basis of history because, as Rachel Perkins points out, the past lives within us. So the history of how you or your forebears came to be in this rural community, whether or not you were accepted, how you or your forebears worked or prayed or parented or loved or voted, or whether you supported one particular community endeavour, can shape generational inclusion and exclusion. So one of the really important steps in an age-friendly rural community is to include that diversity of voices, to reach out to those that are isolated. And we have the opportunity coming out in a post-COVID world is to build on these acts of kindness and care that have helped all of us deal with our social isolation, to actually start to recognize that that's how it feels and to offer that sense of kindness to others. And there's often what's missing in some of the work around dealing with discrimination is including older people in training on how to learn to be an active bystander. And it can be a really important part of being in a rural age-friendly initiative. Sorry, that's me. So the civic participation and employment is sometimes an interesting concept in rural communities because older people do participate and they participate as leaders. They are indispensable in emergency services, and they often don't call themselves volunteers. They just say, we're just doing what needs to be done. If something needs to be done, let's get it done. They're indispensable in the transfer of intergenerational transfer of knowledge in farming, in agriculture, in agribusinesses, as well as small businesses. But we also have significantly higher levels of poverty in rural communities, with higher costs of living and greater variation in earnings. And those earnings are particularly dependent on weather, on soil, on global markets. So we have a number of initiatives happening in our region to support new farmers who are coming into the community who may not have experience with this farmer needs a farmer, where an older farmer will shadow a newer farmer. And also a business that's been set up called Cultivate Farms that brings together people who want to move into rural properties but don't have money, and farmers who want to retire and transition out. And Cultivate Farms has also set up a healthy ageing initiative for farmers who want to stay on the land and improve their health and well-being. So as we come again out of a COVID world, our age-friendly plans of action needs to continue to support and recognise the contribution of older workers and their capacity and need to be in all sorts of businesses around rural communities, and to ensure that lifelong learning both includes U3As and goes beyond U3As, that it's not just the role of a U3A, but lifelong learning and those foundational skills are essential. And we need to think about how our volunteers will come back into work in a COVID safe way. So the last two domains are about communication and health services, and we know how essential both of these are, and COVID's shown that more crucially. So communication is obviously essential to well-being, and in extreme weather events and COVID, survival is dependent on our ability to transfer and receive information. Still, internet access in rural areas is in many cases non-existent, with great black holes in the network and poor quality services, and services that fall out when the fog rolls in. So we need to ensure that there are at least a basis of information that can get into all communities to ensure that information's available. We also know that for older people, they still very much rely on those face-to-face interactions. They value and trust particular people to provide them information they can rely on, and they turn to local newspapers and radio. So we need to build our communications infrastructure around people as much as IT. In Wangaratta here in Northeast Victoria, that need for information was addressed by setting up an information hub that's staffed by older volunteers who are trained, and they provide those face-to-face information and resources as part of a drop-in centre that's in our local town. And building it back, putting infrastructure, communication infrastructure, public infrastructure as part of our economic stimulus going into the future is going to be a really important part of our planning for age-friendly communities. And given the high rates of unemployment, there's also an opportunity when we think about putting IT in the homes of older people, as is often talked about, that robots can help. We can actually think about maybe this is a chance to set up employment opportunities for people of all age to provide home-based care in new and interesting ways. And our last area that I'll address in the time that I've got is to talk about health services. We know that health promotion, the maintaining our functional ability across the lifespan is essential. We just don't want to treat illnesses. We need to do that better, but we also want to prevent and maintain and improve health and well-being in later life. And often the minute we start talking about health promotion, people automatically go to young children and they forget the evidence that it's never too late to start improving physical and mental health and well-being. We've created a resource here looking at how to create age-friendly health services with a simple checklist and assessment tool that can be used by the health services themselves, their boards of management and community members. And it's based on the WHO's primary care modules of workforce, provision of healthcare, the health system itself, and the environment. And the resources will be available to you. But we also know, and the research is absolutely certain, that it's integrating health and social care that really matters. And so here in Northeast Victoria, with some funding from Better Care Victoria and in partnership with all of the health services up here, we set up a systematic approach that has brought together the best practice from the World Health Organization's integrated care of older people and the Institute for Healthcare Improvements 4Ms model. We saw strengths of both of those and gaps for integrated care for older people. And so we created what we've called the Indigo 4Ms framework. We liked IHI's 4Ms as an effective way of talking with older people and their health and social care providers, so that at every interaction, these 4 core areas need to be addressed at the same time in a simple, low cost, efficient and effective way. And so sitting underneath each of these 4Ms are evidence-based tools and resources that can support people in quite the work of ICOPE has shown us that even people, healthcare workers at low levels of training can do quick, simple assessments and seek out assistance from others. And older people themselves can focus on what matters to them and take simple steps to improve their health and well-being. And we've been able to show through an economic assessment of our model, the age-friendly approach against current care. This is in Australian dollars, and it includes both the cost of the healthcare and the loss of productivity in older people if they remain unwell. And we've been able to show significant cost savings over short periods of time if we were to implement age-friendly care in place of the current care people are receiving. And we did that for people in, so community living older people, for people in residential aged care, and for people who only need to receive primary health care. So this is a model that we think is transferable, and certainly a model that can be used for people who just need to see their GP or an allied health professional or a small amount of social care, right the way through to people who need intensive care in our regional hospitals. So we think the age-friendly agenda needs to say that we can deliver integrated health and social care, that we need to implement models like the Indigo 4Ms framework into our health system to redress the extraordinary impact that COVID has had on older people and the attitudes of health workers. We need to focus on prevention and talk about health promotion in later life. And we also, and COVID has shown us this, we need to absolutely work tirelessly to ensure a just long-term healthcare care sector. And for all of those, it will create age-friendly rural communities, not just for older people now, but for our children and our grandchildren into the future, that our policy agenda over the next couple of years can be a significant evidence-based program that can be well monitored and well evaluated, because age-friendly communities have come of age. Thank you. And I'm happy to take questions.
Thank you so much, Kathleen. I think we're going to need to have you back because it seems like we've just scratched the surface on so many of these things. But we'll move on to the Q&A briefly. And we'll start with a question from Mr. Patrick Harkness. He's asking, what type of social and medical programs in rural areas are provided specifically by Indigenous people themselves?
Thank you, Patrick. We, across Australia, there are integrated Aboriginal health services that are run for and by First Nations people. So there is an aim of always for self-determination. And of course, there are great problems in Indigenous health, particularly in more outer, those remote areas that I showed early on, where health services can be difficult to get to. But always in working with Indigenous communities, with First Nations communities, the entry into those communities is through their Aboriginal health services. And they exist in urban areas as well as those outer areas. And of course, they still face extraordinary discrimination. Their health outcomes are poorer. So it's a complex area, and we're getting better at it, I think.
Thanks so much, Kathleen. Next, I think that's such a, I think it's, applicable obviously around the world, but, very relevant for us in the Canadian context as well. So thank you for speaking to that. Next question from Francis. What is the economic activity in these rural towns? What financial resources do older people have? Pensions, private income?
In Australia, we have a universal pension system. So we have that safety net, but it provides a basic income to all people over the age of 67. So if people we have a compulsory superannuation system since 1987. So most men in particular have paid into superannuation. If women were out of the workforce, that compulsory superannuation system doesn't exist. So we have women who don't have the compulsory superannuation component of their income, so rely solely on a government pension. That pension is benchmarked against a cost of living measure, the CPI. In most rural communities, the income sources that exist beyond the pension, if people are continuing to work, are different forms of agriculture, as well as providing services in small rural towns, including obviously home-based care, and hospitals are often the big employers in small communities. And of course, the cost of living is considerably higher. So often people, even on pensions, can still really struggle, particularly if they don't own their own home and they're forced into the private rental market. In those small communities that I talked about that are seen as ideal, and they're beautiful parts of the world to live in, the housing is often owned by people who don't reside in those communities. So housing can be very difficult to access. Affordable housing is difficult, and the quality of housing that you need to age well is often difficult to come by in some of those communities.
Thanks so much, Kathleen. The next question is from Rudy. He asks, have you had any experience or trials with home share programs, university-aged youth or young adults screened and living with older people to provide help in the home in exchange for reduced rent?
It's certainly working well in some parts of urban Melbourne, which is the capital city closest to where I live, and it's the capital of the state that I live in. So yes, that model is working well in a couple of regions in Melbourne. I haven't known it working in rural areas, and I think it's a great initiative, and I think particularly for those communities that are close to some of our regional universities, and perhaps even close to our regional hospitals, where often we have doctors, nurses, allied health professionals come to do placement here from their city universities or city teaching hospitals. That might be a useful thing to consider. So thank you.
Thanks, Kathleen. Question from Rebecca Johnson. She is asking, what support do you receive from your municipal government?
So we have in Australia, we have 3 levels of government: the federal government, our state governments, and then each state government area is divided into what we call local governments, and there are 79 in the state that I live in. Those local governments have all come together under one advocacy organisation called the Municipal Association of Victoria, and the MAV is highly supportive of this work. And provides connection, particularly for local government staff who are working in the age-friendly space, to continue to support that work. The state government area-based grouping, so the Ovens-Murray is the state government grouping here, are very supportive of the work. At a state level, though, certainly at a federal level, it's been very difficult to get age-friendly on the agenda. They revert directly into talking about aged care, and particularly residential aged care, and so it's been a battle to get on that agenda. The other difficulty is, I strongly believe, and the evidence suggests that as well, that because rural is regional, we need to have those mechanisms that bring clusters of local governments together. And yet what we find coming out of our state government is that they'll set up a competitive grant scheme, and having to compete for funds always sets local governments apart. So rather than having the shared pool of funding, which they had in Western Australia, they used pooled funding there. Pulling that funding often brings people together to help that work together. So it's that mixed picture of leadership from some very good people in those organisations, the Municipal Association of Victoria, our local state government initiative here in Ovens-Murray, and still what it feels like those ageist attitudes that seem deeply embedded in governments.
Yes, Kathleen. Dovetailing off that a bit, we have a question interesting question from Brenda Vasquez, and it's really about how to have the conversation about kind of the integration of health and social care. And the main concern she was saying is, or the main barrier that she's noticing is around the sharing of information in the context of kind of privacy between patient and participants.
I think giving control to older people themselves is important. That's why I really have valued working as part of the Indigo 4Ms framework. We've designed that framework with older people themselves as well as with clinicians. So it uses language and ideas that older people get much more quickly often than the health professionals, than the clinicians. And because it's so strongly evidence-based, it says these are the core issues that you need to know and understand. But because it does it in a language that people understand, and it's not disease specific, so it doesn't talk about diabetes or heart disease or cognitive impairment or arthritis. It starts with saying, what matters to you? What matters to you today? What matters to you now? What is driving? What's the purpose and the meaning that you hold for your health and well-being? And these are the key areas that you need to be working on to make sure that you maintain and improve your functional ability. And so diluting it from talking about disease-specific entities enables some of that freedom, because you're not tipping into personal issues in a public space if people don't want to. You're focused on, do you understand your medicines? Who do you talk to about your medicines? Are you taking part in a strengths program? So you don't have to talk about the fact that someone's got diabetes or arthritis to be able to have those conversations.
Right.
So I think it's a tool that can be effective in taking away some of the need to dip into the detail of people's conditions if they choose not to, and to respect their rights not to.
Thank you, Kathleen. So I think we probably have time for one more question. I know there's lots in the chat or the Q&A box right now, though, so rest assured to everybody that we'll make sure that we work our way through these questions with Kathleen off air. But our last question, and I think it's important to touch back on. I know you mentioned, Kathleen, the importance of volunteers. Can you talk a little bit about the role of older volunteers in planning a lot of these age-friendly initiatives?
They're always involved in the planning of everything. So it's actually it's the core fundamental principle that drives this work. This work is with, for, and by older people, and particularly in rural communities where 42% of the people who live there are already over 65. You wouldn't get away with doing anything else, and they have to have the legitimacy that only an older person can bring, to be able to say, yes, that program or that idea will work, or let's give it a go, it's worth giving it a go. It doesn't matter whether that's where you place a park bench or a drinking fountain. If they're not in the right place, they're not going to be used. So it is fundamental to the work we do. And all of the examples that I presented today, many of them are intergenerational, and they all involve and only work because older people say they want to be part of it. Volunteering it can often also be one of those ways people get excluded. So you can sometimes hear people say, well, she doesn't volunteer, she doesn't help out. And so we need to be always mindful that while older people are certainly the heart, soul, social glue of rural communities, services couldn't be provided without them. Not to make a judgment on those who, for a whole lot of reasons, can't or won't or don't like to do that as part of their work and their life.
Thank you so much, Kathleen. Well, I think we're approaching the hour. So on behalf of the IFA, thank you to everybody who's joined us today. I think this was a fantastic session, and a big thank you to Kathleen, who as she's mentioned has joined us from the wee hours of the morning in Australia. So thank you to everyone on board, and we look forward to our next session and hopefully having Kathleen back in the near future. Thank you so much, and have a great day.